Usually when you walk into a clinic with a medical issue, there is this expectation of precision. Like if you break your arm, the X-ray shows a jagged white line, the doctor points to it, and well, that is it. It is
Yeah.
visible. It is easily categorized.
Right. Yeah. It is comforting, really. I mean, the human brain loves binary states.
Mhm.
Broken, not broken, sick,
Oh,
healthy.
exactly. But then you step into the world of endocrinology, and specifically women's health, and suddenly that X-ray machine is just useless. We are looking at a diagnostic landscape that is incredibly murky. So welcome to the deep dive. Our mission today is unpacking a fascinating 2024 medical guideline from the Society for Endocrinology.
Yeah, it is a crucial document.
It really is. It covers a condition called female hypogonadism, or FH. And, whether you are catching up on women's health for a project or maybe navigating the healthcare system yourself, or you just love understanding the strange mechanics of the human body, this conversation is tailored entirely for you.
Because it is the absolute definition of diagnostic muddy waters. I mean, we're talking about young women whose bodies simply stop producing essential reproductive hormones. And the biological stakes of that shutdown, they could not be higher.
Okay, so let's unpack this. When we hear hormone deficiency or estrogen replacement, almost all of us immediately picture menopause in women over 50.
Right.
But this source is entirely about premenopausal women. Some are as young as teenagers.
Yeah, and what's fascinating here is the sheer scale of the biological disruption. Clinically, the guideline defines this as a persistent drop in a specific type of estrogen serum, 17-beta-estradiol, to below 200 picomoles per liter, and that is alongside absent periods for at least 3 months.
Wow. Okay, so below 200. Just to put that number in perspective for you, during a normal menstrual cycle, that estrogen level surges way, way higher. Dropping below 200 and staying there is, well, it is basically postmenopausal territory.
Exactly. It's a fundamental shift in how the body operates. Because estradiol isn't just a fertility hormone, right? It is a master regulator for multiple organ systems.
So before we get into that whole body impact, let's figure out where the plumbing is actually breaking down. Because reading through these guidelines, not all hormone deficiencies are the same. The text outlines two main pathways. We have premature ovarian insufficiency, or POI, and central hypogonadism, CH.
Right. So let's start at the ground level with POI, premature ovarian insufficiency. In POI, the issue is directly in the ovaries. They have either run out of follicles, those are the little sacs that release eggs, or they have just stopped responding to signals entirely.
Wait, so the brain is actually trying to do this job?
Yes, the brain is working perfectly. The pituitary gland in the brain constantly monitors estrogen levels. When it sees they are dangerously low, it panics. It starts shouting at the ovaries by pumping out massive amounts of stimulating hormones.
Like FSH and LH.
Exactly, FSH and LH. So if you look at a blood test for a woman with POI, those brain hormones are sky high, but the estrogen is flatlined. The ovaries simply cannot answer the call.
Why do they just clock out early, though? I mean, what causes a 25-year-old's ovaries to just stop working?
It is a mix of things. Sometimes it is chromosomal, like Turner syndrome. Sometimes it involves genetic mutations, like variations in the FMR1 gene.
Oh, wait, isn't that associated with Fragile X syndrome?
It is, yeah.
Yeah.
Which can affect cognitive development, but bizarrely, it also has this side effect of prematurely aging the ovaries. Then you have autoimmune causes, where the body's immune system gets confused and attacks its own ovarian tissue. And finally, there are medically induced
That's
causes.
damage from chemotherapy or something.
Right, chemotherapy, pelvic radiation, or specific surgeries.
Okay, so in POI, the brain is shouting, but the ovaries cannot hear it. But then we have the second pathway, central hypogonadism. And I'm assuming from the word central that the problem is higher up.
Exactly. In CH, the ovaries are completely healthy. They have plenty of viable follicles, but the brain, specifically the hypothalamus and the pituitary gland, well, it just stops sending the signal to produce estrogen.
Oh, what?
Yeah, so on a blood test, everything is flat. The stimulating hormones from the brain are practically zero, and so is the estrogen. The brain is basically asleep at the wheel.
Let me make sure I'm conceptualizing this right. If the body is a house, POI is when the boiler in the basement is completely broken. The thermostat on the wall is turned all the way up. It is screaming for heat, but nothing happens. But central hypogonadism is when the boiler is totally fine, fully functional, but the thermostat on the wall is just flipped to the off position.
That is a brilliant way to visualize it. And the reasons that thermostat gets turned off in CH are honestly fascinating. You have congenital conditions like Kallmann syndrome. This happens during embryonic development. The nerve cells that secrete reproductive hormones fail to migrate to the right spot in the brain.
And doesn't the text say that Kallmann syndrome also causes a lack of smell?
It does. It seems completely random, but it is a quirk of human development. The nerve pathways for reproduction and the nerve pathways for the olfactory system, your sense of smell, they develop and migrate together in utero.
So if one gets lost on the journey, the other often does too.
Precisely.
That is such a strange, specific biological tie-in. But moving beyond the congenital issues, the guidelines spend a massive amount of time on the functional causes of central hypogonadism,
Uh-huh.
specifically hypothalamic amenorrhea, or HA.
Yes, HA is huge.
Right. And this is the condition triggered by severe stress, massive calorie deficits, or extreme punishing exercise. It really makes me wonder, if someone goes on a drastic starvation diet and their periods stop, is the body just shutting off the thermostat intentionally to save energy?
That is the exact mechanism. It is a brilliant evolutionary survival tactic. In a state of starvation or immense physical stress, the body's fat stores drop. Fat cells produce a hormone called leptin.
Okay.
So when fat drops, leptin drops.
Yeah.
That lack of leptin acts like an alarm bell in the hypothalamus. It suppresses a crucial neuropeptide called kisspeptin.
Kisspeptin. I mean, that sounds entirely made up.
I know, right? Endocrinologists have a very strange sense of humor. But kisspeptin is basically the master switch for the human reproductive axis. By suppressing it, the brain essentially says, we are in a famine. We cannot possibly sustain a pregnancy right now. So it pulls the plug to conserve energy for basic survival.
It is incredible how intelligent the body is. But also, how that intelligence backfires in a modern context where someone might just be training for marathon or restricting calories to look a certain way.
Not exactly. The body doesn't know the difference between a famine and a strict diet.
So true. But let's shift gears. We have established how the estrogen disappears. Now we need to look at why a lack of estrogen actually matters. Society has this terrible habit of reducing women's hormones entirely to fertility. But reading this text, estrogen acts more like whole body armor.
It really does. If we connect this to the bigger picture, it shows why prolonged estrogen deprivation is so dangerous. Take the skeletal system, for example. Estrogen is the conductor of the bone rebuilding orchestra. You have osteoblasts, the cells that build new bone, and osteoclasts, the cells that break down old bone. It is a constant cycle.
And estrogen keeps them in balance.
Right. Without estrogen, that balance is utterly destroyed. The osteoclasts, the demolition crew, they just go into overdrive.
Oh, no.
Yeah, they start breaking down bone much faster than it can be rebuilt. Young women with untreated estrogen deficiency face rapid, severe bone density loss. We're talking about osteoporosis, where bones become porous and brittle, leading to debilitating fractures in women in their 20s and 30s.
Wow.
That is why the guidelines mandate regular DIABETES bone scans for these patients.
Here is where it gets really interesting. If a young athlete loses her period due to extreme training, she might think it is a badge of honor or honestly just a convenience. Not dealing with cramps or bleeding while training sounds great, but you are telling me her bones might literally be dissolving from the inside out because she lacks this master hormone.
It is an accelerated aging process for the skeletal system, and it doesn't stop at the bones. Estrogen regulates cerebral blood flow in the brain. It dictates lipid metabolism in the liver, helping manage cholesterol. It manages insulin sensitivity.
So it's everywhere.
Everywhere. The text explicitly points out that women with untreated POI have a significantly increased risk of cardiovascular disease. Without estrogen, the arteries become less elastic and plaque buildup accelerates.
What about the day-to-day physical symptoms? Because,
Wow.
when we picture estrogen deficiency, we usually picture a 50-year-old woman having a hot flash in the middle of a meeting. Do these 20-year-olds get those same symptoms?
It depends entirely on which pathway they are on. This is a brilliant piece of neurology. Women with acquired POI, meaning their ovaries fail after they have already gone through puberty, they get classic severe hot flushes.
Okay, why is that?
Well, the brain has warm-sensing neurons in the hypothalamus. Estrogen normally widens your body's temperature tolerance zone. Without it, those neurons glitch. The slightest change in temperature makes the brain think it is overheating, triggering a massive sweat response.
But wait, the text mentions that some women with hypogonadism don't get hot flushes at all.
Yes. Women with central hypogonadism or women who developed POI before they ever went through puberty, they often do not experience hot flushes.
Really?
Yeah, their brains never got used to adult levels of estrogen in the first place, or the mechanism is suppressed differently.
That makes a diagnosis incredibly tricky. I mean, a 22-year-old who misses her period but feels totally fine physically with no hot flashes, she might never get flagged by her doctor for a hormone deficiency.
They fly completely under the diagnostic radar. Meanwhile, their bone density and cardiovascular health are silently deteriorating in the background.
So if the lack of estrogen is silently destroying bones and hearts, the obvious answer is to replace it. But replacing hormones in young women is tangled in decades of fear, intense misinformation, and frankly, the wrong medications. Let's tackle the elephant in the room, the fear of breast cancer.
We really have to unpack the medical history to understand this fear. In the late 1990s and early 2000s, there were massive studies like the Women's Health Initiative that looked at hormone replacement therapy, or HRT.
Right.
But those studies focused on postmenopausal women, usually in their 60s. They used older synthetic drugs that increased blood clot risks, and they did show a small link to breast cancer. The media ran with it, and a whole generation of doctors was trained to fear HRT.
But those were women in their 60s taking synthetic drugs. We were talking about women under 40.
Exactly, and the guidelines are emphatic about this distinction. For young women with hypogonadism, their baseline risk of breast cancer is incredibly low. Prescribing them HRT isn't giving them extra hormones that push them over the edge. It is simply replacing what their bodies should naturally be producing right now.
Yeah, the text mentions a breast cancer clock. Essentially, the risk associated with lifetime estrogen exposure doesn't really start ticking until the natural age of menopause, around 51.
Right.
So withholding estrogen from a 25-year-old because you're worried about a 60-year-old's breast cancer risk isn't just overly cautious, it is medically unsound.
It leaves the young woman completely unprotected against bone and heart disease.
And even when doctors get past the fear and decide to prescribe hormones, there is a massive debate about what they actually hand the patient. A lot of young women who miss their periods are just handed the standard combined oral contraceptive pill. The birth control pill, I mean, it induces a bleed, so problem solved.
Far from it. The guidelines argue very strongly against using the standard contraceptive pill as a long-term solution for these women.
Why, though? It has estrogen in it.
It does, but it is a synthetic estrogen called ethinylestradiol. Physiological HRT, on the other hand, uses native 17-beta estradiol.
Native meaning what, exactly?
Native means it is molecularly identical to the hormone the human ovary actually produces. The clinical data clearly shows that native estradiol is vastly superior for building bone density and maintaining healthy blood pressure compared to the synthetic version found in most birth control pills.
Okay, and the route of delivery matters immensely, too. The text says transdermal is king. Why are patches, gels, and sprays better than just swallowing a pill?
It comes down to how the liver processes things. When you swallow an estrogen pill, it goes to your stomach, gets absorbed, and is immediately sent straight to the liver. This is called first-pass metabolism. When the liver gets hit with that sudden, massive influx of oral estrogen, it reacts by altering the balance of coagulation factors in the blood. It slightly increases the risk of deep vein thrombosis, or blood clots.
But transdermal estrogen, like a patch or a gel, that is absorbed directly through the skin into the bloodstream.
Yes, it bypasses that first-pass liver metabolism entirely. The liver never gets overwhelmed. So for women who suffer from migraines, who are overweight, or who have any elevated clotting risks, transdermal native estradiol is unquestionably the safest and most effective route.
You know what is really cool is where the guideline authors looked to prove this. They didn't just look at young cisgender women with ovarian issues. They look at an entirely different field, transgender healthcare.
This raises an important point about cross-disciplinary medicine. Modern transgender healthcare relies heavily on providing higher doses of native estradiol, often transdermally, to young trans women to build bone mass and develop secondary sex characteristics.
Right, because both young trans women and young cis women with female hypogonadism share the exact same physiological goal. They need to build and sustain peak bone mass, which postmenopausal women don't need to do. Postmenopausal women just need to maintain what they already have.
Exactly. And because transgender care has been utilizing these high-dose transdermal protocols for decades, there are massive cohort studies proving that it can be done safely over a lifespan without triggering those huge stroke or clotting risks associated with older oral synthetic drugs. It is a robust, real-world proof of concept.
But if I am putting myself in the shoes of the listener right now, they might be thinking, if transdermal native HRT is clearly the gold standard, and we have decades of data proving it is safe for young people, why are so many women still fighting with their doctors just to get a basic patch? The science is incredibly clear, but the human experience of trying to get this care is completely fractured.
The psychological toll documented in these guidelines, it is just profound. Many of these women suffer from late diagnosis. They spend their crucial teenage years feeling like they are falling behind their peers developmentally. It leads to immense long-term issues with body confidence, intimacy, and self-esteem.
Yeah, the text includes direct quotes from patients recounting what their own doctors have said to them. Imagine a doctor looking at a woman in her 20s with failing ovaries and saying, "You are far too young to be taking HRT," or "You've been on this for 5 years, you need to stop for breast cancer risk." It is wild to read that in a 2024 medical document.
It highlights a massive systemic failure in medical education, and it extends to the bureaucratic nightmare these patients are forced to navigate. Imagine having a congenital condition where you are going to need hormone replacement for the next 40 years just to keep your spine from crumbling. Yet the healthcare system often restricts these prescriptions to a 1-month supply.
That forces these women to jump through bureaucratic hoops 12 times a year, calling the doctor, waiting on the pharmacy, and the text mentions patients frequently facing pharmacy shortages where they are just turned away empty-handed.
It is unbelievable.
You wouldn't tell a type 1 diabetic, "Sorry, we're out of insulin this month, your pancreas will just have to figure it out."
Yeah.
But these women are routinely subjected to arbitrary breaks in their chronic care.
We also cannot ignore the emotional toll of routine medical interactions. Women with POI, who have virtually no chance of a natural pregnancy, are constantly subjected to tick-box medical questionnaires where nurses or doctors ask, "Could you be pregnant?"
Oh, that is brutal. To be continuously reminded of your infertility by the very system supposed to be managing your condition.
Yeah, so.
So what does this all mean for the patient? It sounds like they're fighting a two-front war. One against their own failing biology, and another against a medical system that treats their lifelong chronic condition like a temporary menopausal phase.
This raises an important question about how we deliver chronic care. Knowledge is most valuable when understood and applied. But right now, healthcare professionals in the community are extrapolating 60-year-old menopausal data onto 20-year-old women with FH. It is causing real, measurable psychological and physical harm.
Which brings us to the most emotionally charged aspect of this entire topic: fertility and family building. After addressing the day-to-day survival and bone health of these patients, we have to look at what happens when they actually want to have children. And the paths are starkly different depending on that initial diagnosis we mapped out earlier.
Right. Let's look at central hypogonadism first. In CH, remember, the ovaries themselves are perfectly healthy. They just lack the chemical signal from the brain. So the goal of fertility treatment is simply to bypass the quiet brain and kickstart the ovaries directly. The guidelines recommend ovulation induction.
And that involves taking daily injections of FSH and LH to manually replicate the signal the brain isn't sending.
Yes, it is highly intensive. It requires constant ultrasound monitoring to ensure the doctor isn't stimulating too many eggs at once, which risks dangerous multiple pregnancies. But the remarkable thing is, because the ovaries are healthy, the pregnancy rates for women with CH undergoing ovulation induction are very comparable to natural, healthy menstrual cycles.
Wow, so the machinery works, it just needs to be plugged into a power source.
Exactly.
But then we look at the functional subset of CH, hypothalamic amenorrhea, the condition triggered by extreme stress, overexercising, or undereating. The guidelines point out something amazing here. Psychological therapies, specifically cognitive behavioral therapy, or CBT, have shown actual success in restoring physical ovulation. Wait, how does psychology fix an endocrine problem?
Because CBT